Hello, and thank you. I'm just going to screen share. And can everybody see my slides? Yes? No?
Yes, we can.
Perfect, thank you. Okay. So I'm going to be going through the crying child, predominantly toddlers today. I did the unwell baby in my last session, and I'll be doing slightly older kids in my next session. We're going to go through a few cases together, and this works best if there are people willing to speak up. So the way I'm going to do it is I'm going to present cases that are cases I have all personally seen in the emergency department in the last few months. And we'll work through what information we need, what treatments we need, and these are pretty common presentations. Okay. So this is my reminder that although the pediatrics department will tell you that kids are not small adults, they are also still human. So we don't need to be too scared, and all of your basic physiology does still apply. So our first case, you get this little child come into the waiting room. This is all of the information you have from triage. If anybody knows what NWB means, pop it in the chat or speak up and let me know what questions you'd ask in the history and what things you'd want from physical exam. See, happy for you to speak up. I'm happy for you to just type whatever you're more comfortable with. So NWB means non-weight bearing. So this is a kid who's essentially refusing to walk. As you can imagine, a 5-year-old, that's quite concerning because children should be walking by the age of 5. What more information would we want from parents, from the nurses at triage? What things would we be worried about? Hip development is a good one. Kid's a little bit old, but you can have missed developmental hip dysplasia that presents in children of this age. But that is something we definitely need to keep an eye on. Another big thing we need to see is if there was any trauma. Has this kid tripped and fallen? Is there a risk of fracture? You'd ask about genetic diseases in the family. It's a good suggestion. So in pediatrics, one of the most important things is the family and social history. Where does the kid live? Who's at home? Who's looking after the child? Do they go to school? Have they had their immunizations? Was the pregnancy normal? Was their development normal up until this point? Muscle atrophy is important, but it's unlikely they'll have come to the emergency department with muscle atrophy because it takes a little bit of time to develop. So we get some more information from mum. And she says, so the first bit, can you see my cursor? Yes, okay, fine. Yeah, fine. So this first bit means up-to-date immunizations. So they've had all of their immunizations they should have had until this point. No SW means no social worker. So we're not concerned from a safeguarding point of view initially. Normal pregnancy and delivery, so no risk factors, lives with mom, 2 siblings, ages 2 and 7. This is the only history you have. Why have I mentioned had a cold last week? I'll be very impressed if anybody gets this right. I didn't know about this last. Any wound infection? So we haven't looked at the kid yet. We don't actually know if there is a wound. But we'll say in this case there's no wound. When you go to examine the child, they really, really don't want to stand. Anytime mum puts them down, they just start screaming. When you put them on the couch, they're not moving their leg at all. You're able to passively move it, so they've got good range of motion. They can feel their foot, they can move their foot, they've got good arterial blood supply, but they're just absolutely refusing to move it. Has nothing you can really see, no redness, no inflammation, and they really, really don't want to walk. So one of the ways we test whether kids are just being fussy or whether they actually are in too much pain to wait there is you put mom or dad in one corner of the room with some sweets or their favorite toy, and you put the kid down in the other side of the room. And if they scream and shout but go to mom, that's a relatively good sign that they're just pretending. If they just sit down and refuse to move, you're a lot more concerned that there's something going on with that leg. Okay. So our main differentials in this age group is we don't really have a trauma history, in that the kid hasn't fallen off something or twisted something. There isn't a pinpoint thing that we can see. But we do have this history of a cold last week. So when kids get a viral infection, you can have a post-viral inflammation. So the way you get a post-viral cold, you can also get irritation of the synovial fluid. And one of the biggest joints of the kid is the hip. So you get what's called irritable hip, about a week or two after the infection. Somebody's asked, was it a bacterial cold? We have no way of knowing that. They had this cold last week. At this time of year and with cough and cold symptoms, it's much more likely to be viral than anything else. So what we do is we'd get an x-ray, because although we don't really have a history of this kid falling over, they might have fallen over and broken something, and we get bloods. Because if their blood tests show that there's raised inflammatory markers, then we need to be worried that this might actually be a septic arthritis instead of just an irritable hip. As with all things in pediatrics, there will be a guideline. So red flags in the top right-hand corner are things you need to watch out for that mean it's more likely not to be an irritable hip and more likely to be something a little bit more concerning. And these are all of the processes you'd go through to rule out whether it's a fracture, whether you've got irritable hip, whether you've got any DDH, as somebody mentioned before, whether there's any septic arthritis. Okay. And treatment for this, if you have a toddler's fracture, which is unlikely given the history, but might show on an x-ray, is normally just analgesia, and you can put a back slab on. It'll be followed up in a week or two by orthopedics. If there's a child with irritable hip, it's essentially just ibuprofen and paracetamol. Monitor until the kid gets better. If they don't start walking after 2 or 3 days, you need to be concerned. And infected arthritis would be admit IV antibiotics. And they'll need to work up under orthopedics depending on how bad it is. Do we have any questions about irritable hip and also just leg injuries in kids in general? You do have to be quite opportunistic with your physical exam. You can't go about it quite the same way in adults. It needs to be made a bit of a game to see which bits you can get the child to do. So irritable hip is a post-viral phenomenon. I wouldn't necessarily say it's a complication because it's quite common. It doesn't cause any lasting damage. But yeah, it happens a week or two after a virus normally. And yeah, it's an inflammation, and it does just go away on its own, the same way you'd recover from a viral cough or cold. Doesn't need any treatment, just if they've got a temperature, bring it down, pain management, and keep the kid comfortable so they can try and walk. Okay, gonna move on to the next case. It would be really good if people are able to either post in the chat or speak up. I won't pick on anybody apart from Sarangama. So no need to be scared. So the next child you get asked to see is this little kid. The nurse actually comes to get you, and they're not next in line, but the nurse says, I'm a little bit worried about this one. I think you should come and see them. Any suggestions? So you've got a very anxious mum who comes in and says, I had a really, really bad pregnancy, I had eclampsia, baby had to stay in NICU for almost a month. Does anybody know what with the lights might? So yes, somebody said icterus. That's a really good suggestion. And it's blue light therapy for increased bilirubin in the kid. I'm not going to talk about neonatal jaundice in this lecture because it will take far too long. But parents do often describe it as they were admitted under NICU for lights because that is the mainstay of treatment. When you go and examine the kid, they're quite warm to touch. And mom said they had a really high fever at home. She measured it at 39.6. In the department, they've had a fever of 38.2, so still febrile. They live at home with two older siblings. There's no social worker involvement, and one of their siblings is also ill. Mom's a bit worried because child's not eating much. So up here in the triage notes, I've said OFC. OFC means oral fluid challenge, and it's essentially you give the child 10 mils per kilo orally with a syringe of any fluid that they will drink, so water, milk, juice, just to see if they will drink it, because that's the bare minimum that they need to survive before getting dehydration. Got a couple of comments coming in. Epiglottitis, yes, it's something to be concerned about, but up to date with immunizations means the strep A infection is relatively rare. Any swelling in the throat, yes, definitely a good idea to have a look in the throat. It's important in children to do a full ENT exam. So you have to look in their ears as well, because kids with a throat infection will very often have some ear inflammation as well. And in fact, children under the age of 3 with tonsillitis tend to present with ear pulling and ear pain more than with throat pain. Is there a rash? Really good question. There's no rash in this kid. I think my last lecture is on YouTube and I covered rashes in babies in that lecture. And it's a really important thing to check. So we go through, the child's still got a fever, they're quite unwell, but they are passing their oral fluid challenge, they're tolerating fluids. Mom says she's been unwell for about 3 days. She's drinking small sips of water throughout the day, but she's not eating anything at all. She usually goes to nursery, but she's not been in the last few days. When you look in her throat, there's not swelling off her throat, but she's got big, red, inflamed, swollen tonsils. So what do we think the diagnosis is? Tonsillitis, exactly. So then there comes this question of viral versus bacterial tonsillitis. So we didn't see any exudate on the child's tonsils. There was no little white patches, which means it's most likely not bacterial. And with viral tonsillitis, you do get this very, very high fevers of 39, even 40 is not uncommon to see. So the thing that you need to be careful about here is mum said it's 3 days of history. So after 3 days of a viral infection, you should be starting to improve. So this might be bacterial, even though you can't see the exudate patches. Anna, you've got your hand up. You can just unmute. That's fine.
Oh yeah, sorry. So why did you say? Can you repeat again? Why would you exclude bacterial infection?
So initially, if you look at a child's throat and there's no white patches of exudate on their tonsils, typically unilateral, it's very unlikely to be bacterial, because bacterial tonsillitis will always produce exudates. However, a viral infection should be improving normally by about day 4 or so. And if this child's quite unwell, so something we do in tonsillitis and in children very regularly is we say, look, mum, this is probably a viral infection. Keep going with paracetamol, keep the fever down. There's a local anesthetic spray called Diflam, which you can spray in the back of the child's throat, makes them a lot more comfortable, makes them tolerate fluids and medications a lot better. However, if the fever still isn't going away after 4 or 5 days, we'll prescribe you some antibiotics. You don't need to get them today, but if you need them in a couple of days, then you can start giving them, because a viral tonsillitis should have improved by day 5. So even if we're not seeing exudate, although it's very unlikely to be bacterial, it gives mum that reassurance, because otherwise they're just going to come back to ED in 2 days and you rinse and repeat the same problem. Does that make sense? And does that answer your question, Anna?
Yeah, thank you. And would you also take, just to completely and officially exclude the bacterial infection, would you take the quick test and also the like sample from the throat?
I wouldn't,
Uh-huh.
because it's not going to change your management. Yes, the textbook answer is you should do that and you should wait for the results, but most hospitals don't have a lab that will run it on site. It'll have to go off site. You're going to give mum the antibiotics anyway, because otherwise she's just going to come back tomorrow. And actually trying to get a throat swab from a 4-year-old with tonsillitis is not worth it. Even trying to look in a child's throat that's in that much pain is really difficult, because they will fight you just trying to get the tongue depressor in. And it will be very painful for them. So actually, it's not going to change your management. You're not going to get an answer in a quick enough time. So practically, there's no benefit to doing it, even though, yes, theoretically, you should always test for things before you give antibiotics. Do you kind of understand the reasoning?
Yeah, I understand the reasoning, but then if you're still, if you're still giving them antibiotics and telling that if it doesn't improve in 2 days, take the antibiotics, why don't take I mean, I understand that it's painful, but still prescribing antibiotics and taking it without the necessary cause would just damage the immune system. Not damage, but
If you've got a 5-day history of fever and tonsillitis, you don't need a swab to prove that's bacterial. You wouldn't have worsening fever on day 5 of a viral illness. So you've got the diagnosis, and we do a lot of this in pediatrics, of you get the diagnosis clinically and you don't necessarily have the empiric evidence. So if a kid comes in with fever, I probably wouldn't even do bloods on her, because I don't necessarily need that empiric evidence to prescribe the antibiotics. I am confident on my clinical diagnosis to prescribe.
okay, I
Are you
see.
understanding the
Yeah,
slight difference?
yeah.
Okay. So these are the NICE guidelines on fever under 5. And when you send mum home, these are the things you need to make sure that they're ready to look out for. So if child starts struggling to breathe, if they're not tolerating any oral fluids, if the fever persists beyond 5 or 6 days. Now, in this case, if we're saying you're not going to give the antibiotics till day 5 of the fever, I'd say give the antibiotics 24 hours to work. So I'd say wait 6 days before you come back, unless they've got other red flag symptoms. If you just Google fever under 5 NICE guidelines, this table will come up. It is basically useful in anyone under the age of about 8, of things that you need to be worried about if they've got a fever. Anything in the red column, the kid would be admitted probably under HDU. Anything in the amber column, I probably wouldn't be happy sending a child home, unless it was a very soft 1 point and mum was very sensible. So a lot of pediatrics is, as we spoke about earlier, based on your clinical judgment as opposed to on empiric evidence. Whereas in adults, we tend to wait for the kind of either the bacterial growth or the raised inflammatory markers or something like that. Whereas in children, we really don't take bloods very often. We don't take swabs very often, because it's much harder for a child to lie to you. So you can take your clinical exam at face value. And the other thing is that children tend to compensate really well until they don't, and then they fall off a cliff. Whereas adults tend to get ill more progressively. Do we have any questions on tonsillitis, fever, or antibiotic prescribing in general?
Sorry, and for this case, for how long would you prescribe the antibiotic?
So I would go on local guidelines, because every hospital will have their own, particularly for antibiotics, prescribing guidelines based on what the most common organisms in that specific community are. So at the moment, we'd just go Pen V for 5 days, because that's my local hospital guideline. It tends to be 5 days of whatever the antibiotic is.
Thank you.
So this is my favorite case in pediatrics, and it's possibly the most satisfying thing you will ever do as a doctor. You get a 2-year-old kid who comes in holding her arm. She won't let anyone touch it. She won't let anyone move it. And she's just screaming if you try. What are we thinking? Dislocation? Maybe of what? Shoulder? Possibly. But look at where she's holding. Subluxation of radius. I am very impressed. Yes. So this is a very, very typical history of a pulled elbow. So up to date with immunizations, no social worker, lives with dad, not mum, 3 siblings, they were older than her. The history is she was out with her cousins. Her cousins are 16, 17 years old. They were walking down the pavement, swinging the child between 2 of them, having a great time. Suddenly, child just starts crying in the middle of the road, completely refusing to move her arm, but is otherwise well. And this is another example of where in pediatrics we just go based on history and clinical exam. If I'm able to passively move this child's arm and they've got good range of motion passively in their elbow, purely with distraction, you can give them Calpol, but it takes too long to work. I am confident in saying that that is a pulled elbow, and I wouldn't necessarily need to do x-rays. The things to look out for are any of these red flags. So these are all of the things that if there's any of this in the history, I'd be a bit concerned that, is this not a pulled elbow? And I'd get an x-ray just to make sure. The thing with x-rays is the subluxation of the radius is a subluxation from the annular ligament. Ligaments won't show up on an x-ray, and positionally the radial head isn't fully formed at this age. So you would only see the central fossification, which would be in line regardless. You wouldn't see a fully formed radial head. You're exposing the child to an unnecessary dose of radiation, which is a much bigger consideration in pediatrics. Age outside peak prevalence. Who wants to guess what peak prevalence is? How old does a kid have to be before you start thinking you're a bit too old for this just to be a pulled elbow? So we're really looking at children under the age of about 3. In your 3rd year of life, so up to the age of 4, will be when your radial head begins to ossify properly to its full extent, and then you can't sublux it because you don't have a cartilaginous edge. The peak age is say 1 to 3, purely because the mechanism for a pulled elbow is opposing traction. And until a child can stand and walk, it would be very hard to get that mechanism without physically gripping their arm in 2 ways and pulling, which we would hope parents wouldn't do. So typical mechanisms is exactly this. Child is walking between 2 adults, being swung. The other one is dad's swinging child round in a circle, kind of pulls their elbow out. Or while you're walking, child slips and falls, and mum or dad instinctively pulls upwards to try and stop them falling. Joint will pop out. The only thing you need to be a little bit careful about is if the history doesn't match what the child says and what the parent says, the history isn't consistent, you just need to keep an eye out for safeguarding and non-accidental injury. And you'll often need to document, I have no concerns about non-accidental injury when you're discharging this patient, because it's quite an easy one for missed abuse. It's not something anybody likes to talk about, but it's something you need to be aware of. The reason I said that this is one of the most satisfying things you will ever do as a doctor, you don't need any medications and you don't need any procedures. Realistically, all you need is some bubbles or a toy to distract the child, and you can just pop it back in department. So there's 2 ways to do it. The first way is hyperpronation, which is generally what we try first because it's quicker, easier, and has a higher success rate. So you place your thumb on the child's radial head, and that's not to put pressure on it. That's just so you can feel the click when it goes back in. You hold their hand and you just hyperpronate until it clicks back in. That's never not worked for me. But if that doesn't work, the other thing you do is supination and flexion. So exactly the same thing, but backwards. Thumb on the radial head to make sure that you feel the click. You supinate their arms, so they bring their palm upwards and flex the elbow in. And as you flex, it should pop back in. Almost immediately, child won't be in any pain, will be happy, playing, moving. As soon as the child moves their arm, you can discharge them from the hospital, and that's it. Things to tell mum and dad is that once it's happened once, it will probably happen again. And just to keep an eye on it, try not to swing the child by their arms and elbows because it can keep subluxing, but it doesn't cause any lasting damage. Any questions on general injuries, pulled elbows, putting it back, or non-accidental injury and things to look out for in terms of safeguarding? No, we are flying through this. We go onwards to our last case of the day. So you have this kid who doesn't want to talk to you at all. She's just sat in the corner. And when you call them through from the waiting room, she still doesn't want to talk to you. Mum has to pick her up and bring her in. She sat in the corner of the examination room. Mum says she's just refusing to go to school today because she needs to be. What do we think? Any suggestions? Questions you want to ask, you don't need to go straight to a differential. Yep, UTI is exactly where we're going with this. The thing to be wary of is, especially in children, they won't necessarily tell you the symptoms straight away. So this poor girl essentially had just refused to go to school because yesterday she'd had 2 or 3, I can't remember, accidents while at school and didn't have a change of clothes, was really embarrassed because kids are mean. And mum was at her wit's end because this morning she's trying to get kids to school. She's got some other siblings. The child screamed and shouted and said, "I'm not going to school." Mum couldn't get a GP appointment, so she came to the emergency department. She didn't know what to do. We haven't got a urine sample yet, but we're trying for it. And child's had a fever in ED. Who wants to guess what the most important comment I've written down there is from the history? Social. I've said she lives with some siblings. Mum's very stressed. No diabetes is a good one. We haven't got a urine sample yet, though, so we're just checking on that. And I wouldn't necessarily do a capillary glucose. So it's this first line, no immunizations. Child's come in. So this child has a fever of 37.4, which isn't that high. If a child came in with a fever over 38, having not had immunizations, it doesn't matter how unwell or how well they appear. You need to do blood tests, A for inflammation markers, but B, you need to do blood cultures and urine cultures because they could be growing anything that we're not used to treating. And if they've got something that is previously eradicated, A, they need to be isolated from other patients, and B, we'll need to tailor the antibiotics because all of the antibiotic prescribing guidelines assume that a child is fully immunized and therefore will not be infected with one of the organisms with which they're immunized against, which is really, really important. And you'll often get parents trying not to tell you that their kids not had immunizations. So it's really, really important to make sure you're asking those questions. Okay. So we managed to get a urine sample. Urine sample shows no glucose, no blood, and a little bit of nitrates. So this kid has a UTI. The diabetes comment is really, really important because you will get a lot of type 1 diabetics. either presenting just with polyuria and polydipsia, or they'll present in full-blown DKA. Okay. So again, in adults, we do a capillary finger prick blood glucose. In children, if we can get a urine sample, we try to dip the urine first because we don't want to traumatize children and keep pricking them for blood when there's no need. Any questions on this child or immunizations or UTI antibiotics? Oh yeah, and then for antibiotics, again, I'd go by like local guidelines. Most places in the UK for a female, it's 3 days of nitro. And for a boy, it'd be 7 days of nitro. But I'd be a little bit worried if there was a UTI in a male over the age of 6 months. I'd be questioning why. Any questions? Is that clear?
I just have a question regarding the immunization. So
Yeah.
if a child comes and then after some time the parents tell you that the child haven't had any vaccine, what as a doctor, how should you proceed if the parents still don't want to vaccinate the child? What's the guidelines in that case?
So, unfortunately, poor decision making doesn't mean you don't have capacity. Just because you disagree with the decision not to vaccinate a child, you can't tell the parents that you're going to vaccinate the child anyway. You still need consent. So in the emergency department, I wouldn't necessarily address immunizations going forwards. I would kind of go with, okay, you haven't immunized your child. That's an issue. We can discuss it later. But right now, your kid's sick, and let's work out what we need to do, because you need to brace yourself that if a parent isn't vaccinating their kid, are they going to fight you about giving antibiotics, hospital admission, fluids, and blood tests? And you kind of need to pick your battles. In an ED setting, you want to win the battle about giving the child antibiotics and doing blood tests. And the battle about vaccines is something that the pediatrics team or the GP can and will pick up. So that's from an ED perspective. From a pediatrics and GP perspective, when I've encountered patients like this, I try to find out why they're not vaccinating their children, because most parents don't want to harm their kids. They're not going to say, I'm not vaccinating them because I don't want them to have this. There'll always be some underlying concerns. And particularly with the MMR, this thing about autism and Down syndrome comes out a lot. And actually, you can offset, okay, if you don't want the MMR because you feel there are associated risks, you can look at getting the three vaccines separately, and that will still protect your child. And it's about having a discussion with the parents where they feel that you're listening to them and that you're on the same team. If you turn around to a parent and say, well, there's no risks involved there, all the parent's going to do is become defensive because they feel there are risks. And whether that's incorrect or not, you're then creating a head-on argument. Whereas if you go, okay, I appreciate your risks, you feel there are risks, let's look at alternatives that will still protect your child. That's a bit of a better way to go. But it's a really difficult one. It's a really, really difficult one. Does that sort of answer your question?
Yeah, it makes sense. Thank you. And I also have another question regarding the previous case with the dislocated elbow.
Yep.
If it keeps on occurring like several times, twice more, for example, is there some complication that can remain in the elbow of the child?
No.
Even after? Okay. Okay.
It's really weird when you think about it, because it shouldn't happen and there should be some consequences, but they haven't found anything.
Okay. Thank you.
Okay. I'm going to move my slide on slightly. Oh, that's one slide. And stop screen sharing. If anybody has any questions, I will stick around. But thank you for coming. Thank you for listening.